In Scotland we have particular problems in oral health, and a great effort has been made in recent years to try to improve this, both by education of the population and by making access to dental care easier. In this presentation, the evidence for change will be considered. It is important that the correct approach to oral health improvement is made, and measurement of the effects is paramount. In order to get across the right message, we need to gauge it to the population. In industry, the importance of message is always apparent. We may think that a company like Dell is in the business of computers, but their message is that they are selling solutions. Zurich may produce insurance, but they would say that they're selling peace of mind. Hotpoint produces washing machines, but they sell convenience. Likewise, Fendi may make handbags, but sell dreams. So what are we trying to sell? First of all, we want to have an effect on the health of children. There certainly seems to have been an improvement in dental health in children, especially those in the higher categories of society. The DEP-CAT scoring is from high social category 1 to the most deprived areas, 7. But we still see a significant difference between these categories of children when we look at their dental decay experience. Similarly, there is still a difference in the incidence of cleft palate across the social scale. And when we look at the progress of cancer patients, there is a clear distinction. Living in Glasgow gives a predicted life expectancy of over 70 years, higher in females than males. If you live in Edinburgh, you're likely to live longer. But let's look at some other places where we might consider moving. A female living in the USA could expect to live for almost 3 years more than her Glasgow friend. The average for the UK as a whole is much better, and someone living in Japan would outlive them all. While in Iceland, despite the recent difficulties, and presuming this does not include asthmatics with all that dust around, a female has almost 6 years more to live. This graph shows the events that can influence health as we grow from birth to adulthood. Each of these influences whether a subject will remain healthy, how long they'll live, and inevitably what health interventions they may require. Should we therefore be teaching these health messages? So what are we doing now to effect a change in lifestyle? The Childsmile programme was set up in the last few years and is already having an effect on child dental health. The core brushing programme is the mainstay of the programme. The integration of care into dental clinical practice maintains the links, and these are integrated into the education system from early stages. The toothbrushing programme includes the basic tenets of dental care, and this includes an early intervention to teach proper brushing at a very early stage. The links into dental practice are important, and those with general medical care are good, starting with the registration of a new baby into the programme by the health visitor. The dental health support worker can then take on the case and support the family in the early stages. The primary dental service takes up the case, and children can be automatically registered into general dental practice, with the provision of preventive care as eruption of teeth commences, and regular dental care then becomes a part of the life of the child. And the support worker is there to add extra support to the family if required at any time. Fluoride application and the use of fissure sealants for children at risk of decay is a major progression in preventive care, and this can be carried out by the PCD within the team. And the programme fits well with the rural population, with mobile units available to get to the more remote communities in order that the same standard of care is there for everyone. We therefore have a continuing care pathway from birth to adulthood. The patient becomes part of a structure of care where details are recorded relevant to individual cases, setting up a full record with details of all aspects of the patient, including those factors which may affect their acceptance of care. Using all this information and data from many studies, a personal care plan can be provided for each patient. But are we having any effect? Going back to the data on decay, we can see that while the most deprived social levels have more problems, these are in fact being managed, and the percentage of children with decay is decreasing, so that the 2008 figures show a great improvement when compared with those of 1994. And we can see from this graph that we are reaching the target for improvement set for the inspection programme. When we look at the state of the nation's teeth over the years, we see an interesting trend in the level of decayed, missing or filled teeth. In 2000, Scotland and Northern Ireland are well down the scale. By 2006, things are improving in Scotland, if not in Northern Ireland, and the Midlands and South of England are static. If we then break down the figures by Health Board, or PCT, we can see that there is a distinct improvement in many areas of Scotland, while there are still areas of the UK where dental health is still a significant problem. We can also look at the improvement in dental health in Scotland compared with other parts of Europe, and how this has changed over the last decade. The nation has moved from its position near the Czech Republic in 2003 to be on a par with France in 2008. However, when we look at hospital admissions for children in Scotland, the majority of these are still for dental procedures. This histogram breaks down the figures for DMFT over a similar period, and these histograms show the figures for individual countries. Note that the data for Northern Ireland are collated slightly differently. When we consider adult dental health, there is an improving situation over the years, with many more people retaining their teeth, until we see in the past 12 years that 90% of adults don't lose their dentition. And the figures again show that the targets are being achieved. Concern is raised about access to dental care and the registration levels of patients. However, the targets set for registration are being met. The objectives for our national government have been recently set, and 5 areas are being targeted. The priorities must include health, and this is in a setting of a fair, safe society which looks for solutions and sets these into the environmental challenges. The Action Plan for Scotland, Better Health, Better Care, sets out how we hope to achieve this, setting health as a major factor for other targets to be fulfilled. The main aim of this objective is to look across the population to enable all citizens to have access to a high standard of care. We still have a way to go, and we still have challenges to achieve.